The streetlight effect dates back to a fable by a Turkish philosopher Mullah Nasruddin. The story goes that Mullah had lost his keys and spent hours looking for them under a streetlight. But all that time, the key was lying in the dark. This observational bias can be found in many fields where we look for solutions where they are easiest to find, not where they are likely to be found. This is also the effect that we uncover in our paper analyzing AI efforts in global health, with a focus on applications in the global south. Many of these are motivated by the shortage of expert human and technical resources in underserved settings. Efforts to advance AI in global health have only multiplied during the pandemic. AI systems have been used to determine who gets vaccinated, for cough based diagnosis, and for disease forecasting. We need to ask questions of these systems being deployed. Who will be using these systems? Where is the data coming from? And how is it being collected? And how does AI fit into the broader ecology and work practices? We focus on the view from the front lines in our own work. AI would require humans to collect data, use the application, or implement its recommendations. In many countries in the global south, these are frontline health workers. They provide care directly to their communities and serve as an individual's first point of contact with the healthcare system. We reviewed 347 academic and grey literature to identify applications being proposed predominantly in the global south. We then considered these in light of ethnographic data that we collected over 3 years with frontline health workers in an underserved Muslim majority region of Delhi. This is a region that has been determined to be at high risk of disease by the state government. We found that over 70% of applications for AI were either around diagnosis or disease surveillance. Other applications included risk assessment, chatbots, behavior prediction, data quality control, and data digitization. AI development was largely led by Global South researchers, but rarely in engagement with other local non tech actors. This led to several gaps in assumptions about local contexts. Our ethnographic data showed the need to consider the broader political and organizational context that AI is situated in, the existence of competing knowledges such as complementary and alternative medicine and religious practices, the complexity of patient choice and agency in seeking care, and the many invisible frontline health workflows. For instance, we found that health workers are frequently called upon for quick response, like we saw during the pandemic. But the disease surveillance applications we reviewed rarely considered the impact on their workflows. Health workers also spend a lot of time planning workflows and focusing on more underserved households, and there's a risk of distorting priorities with new tools for diagnosis and planning. They also attended to the socio-cultural dimensions of health, especially in patriarchal households, and these are rarely captured in data. They were also already involved in a lot of data collection, and additional data needs for AI could overburden them. So, where do we go from here? Many of the challenges we uncover through our analysis are not new. There's a lot that we can learn from past ICT interventions, both the rare successes and the many failures. First, there's a need to foreground user agency. We must expect targeted users to not use these systems at all, use them in unexpected ways, or work around the systems altogether. Many ICT systems are also motivated by the promise of scale to help leapfrog development. We need to critically question the unit and nature of scale. We also recommend a move towards supporting self-determination by communities on the development and use of AI. One approach is for researchers to work closely with the community over the long term through methodological approaches such as action research and offering technical support after the project ends. We also need to think about sustainability of these applications in terms of resource extraction. We must consider other technical and non-technical solutions before settling on an AI solution. We also need to foster solidarity and exchange knowledge across disciplines and geographies. Many of the papers we reviewed asked narrow questions. They asked how well we can predict a disease with a given data set, rather than why are patients unable to access treatment in the first place. Finally, we recommend focusing on common struggles that communities are facing when translating systems across contexts or collaborating with others. This means supporting the global struggle of frontline health workers for better pay and recognition.